Elranatamab is a BCMA CD3 bispecific. In the MagnetisMM-30 study, we observed a 61% response rate, 37% CR rate. Among patients that achieved a CR, the likelihood of maintaining response at 30 months was approximately 80%. And so really the depth of response matters. And so the idea here is, can we add in additional treatment that can improve the depth of response? So Iberdomide is a newer generation, it's a CELMoD, newer generation cereblon binder that can lead to, enhanced T cell activation and T cell function. And the thought here is perhaps it will improve responses with T cell redirecting therapy that activates T cells. The study is designed in two parts, a dose escalation portion and a dose optimization part 2. The data presented at this meeting was the part 1 dose escalation portion. And the study evaluated patients that were in earlier line settings, so 2 to 4 prior therapies, IMiD and PI exposed. 2 cohorts were evaluated: Elranatamab weekly with Iberdomide 1 milligram for 21 out of 28 days, and another cohort of Elranatamab every other week, also with Iberdomide 1 milligram, 21 out of 28 days. A total of 22 patients were enrolled across these cohorts. The follow-up time for the first cohort is approximately 9 months, and it's about 5 months for the second cohort, so follow-up times are relatively short, but sufficient for evaluation of safety and preliminary response assessments. Patients received the standard Elranatamab step-up dosing, 12 milligrams, followed by on day 4, 32 milligrams, and then 76 milligrams was the full dose at day 8, and then Iberdomide was added after they completed the step-up on day 15 in both cohorts. The main safety signal of the combination was neutropenia, with about slightly over 75% with grade 3-4 neutropenia. 60% of patients received G-CSF. CRS was seen at a typical rate, approximately 60% of patients. Mostly it was grade 1. None of that required discontinuation. Infections were seen in 40% of patients. Very few grade 3 infections, actually, less than 10%, which was encouraging. Patients almost uniformly received IVIG once IgG levels were less than 400. So in terms of response, the response rate across both cohorts was 95%. And actually in the dose level, it was the -1 cohort with Elranatamab every 2 weeks. The VGPR rate was 89%. The CR rate was 46% or 45.5%. So very encouraging response rates and fairly high depth response rates. The PFS OS data is definitely immature and will require additional follow-up. So the take-home point here is that the combination is like super active. Neutropenia is the main sort of adverse event, but can be managed with G-CSF administration. And the dose finding study is, the dose optimization study, the part 2 portion of this study is ongoing with enrollment now.